Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. So this procedure is a continuation, or if you like, a sequel of procedure number 1061, titled Extremely Challenging Earwax Removal, which you can watch if you go to my YouTube channel. Look at my recent videos. I think I uploaded it last Wednesday or Thursday. If you did watch that video, I would have advised that I would be uploading their right ear. So that particular video is of their left ear. That will be uploading their right ear sometime this week. So this patient, I'll give you a bit of a backstory. They attended last Wednesday as an emergency appointment. They went to, I think it was either a walk-in centre, an emergency walk-in centre, or to A&E, and they had severe pain in this right ear. They had got water in and they used a cotton bud, and they were in excruciating pain, and they were recommended to see myself. And this was the worst ear, but if you watch that video 1061, it'll put it in perspective, because that procedure I did in their left ear was extremely challenging and complex, and this more so. Now, the patient is of South Asian descent, so it has a darker skin tone, and the wax is very dark. It's oxidized. So at the beginning, at least, it was quite difficult to separate and to know where the boundaries are, because the wax is almost camouflaged. Now, this outer half, the more lateral earwax, came away pretty straightforward, if I was honest. And I thought, well, this should be a nice and simple procedure, but it's this medial bit. This was extremely difficult to remove, and it had been lodged, and you can normally tell if a patient goes to the hospital or emergency walk-in centre as an emergency and they call in as an emergency, you kind of know. I shouldn't have been as naive as I was. I should have learned through the years I've been doing this that it's not as easy as I assumed it would be. And in terms of my success rate, when I first started performing earwax removal, I think it was about 2015, I'd probably say I would probably have to get back 1 in 20. So like a 95% success rate, I think, if my maths is correct. So that's how I started off, so probably 1 a week. Then I probably, about 3 years ago, or a couple of years ago even, I would say my success rate was probably, if I do it in terms of, so initially 1 a week I'd have to get back, then it was probably 1 a month I would have to get back. And now it's probably maybe 2, possibly 3 a year. So now I can't, it's never possible, I don't think, to have a 100% success rate. And if anyone tells you otherwise, I think they're probably telling you a bit of a porcupine. That's because I work with ENT surgeons as well, and some of my good friends and colleagues are ENT surgeons, and they themselves would tell me that earwax removal can be really hard, and even they have to get people back. So if anyone who's watching this video is new to earwax removal or thinking of doing earwax removal, don't be disheartened if you're having to get people back. With experience and as you increase your skill level, that your success rate will improve over time. And I'm quite candid and open about it. Yeah, initially when I first started, it's probably 1 a week, and from that to probably 2, maybe 3 a year, it's a big difference. And that's taken years of practice and dedication and hard work. And so to anyone aspiring to become an earwax removal specialist, there is a journey. And this is a prime example. Now, this is a very extreme case now. The main difficulty was the patient was in extreme pain. So when they attend with extreme pain, the first thing the patient asked, is this going to hurt? And you have to be honest with the patient. They're already coming with severe earache, and I'm going in their ear trying to remove this boulder of wax. So the way I phrased it was, I'm going to be as gentle as I possibly can be. And of course, at any stage it's really uncomfortable, do let me know, and we'll stop immediately when I'll come out of the ear. And if you wish for me to continue, we can. But there might be some discomfort because already you're in pain. Now, I don't know if you can look around the edge, the ear canal has swollen here. So it's wrapped itself, it's swollen over the wax, it doesn't want to let go. Like this wax is caught in the jaws of the ear canal. Now, this is something that I don't often do, and that's using an ear hook really, really deep in the ear, but I had no option because this wasn't going to come out any other way. And although I managed to maneuver the ear hook into the plug of wax, it just wasn't prizing away, and the patient was extreme pain after that. And so we just took a couple of minutes break, and I went back in. Because sometimes with an ear hook, although you don't extract the plug in one go, you can dissect it like I did here. You can break it into little pieces, and I was hopeful that now that I've broken it up, it would come out. So going back to video 1061, what I initially did, please do go watch that video. I started off in this there right ear, and after 4 or 5 minutes, I kind of realised, as soon as I moved the lateral bit of wax, I kind of realised that this is going to be quite tough. So I said to the patient, let's focus on their left ear, which I thought would be a lot easier. And it turned out it was easier, but it was still very difficult. And then I'll come back to this right ear. So then I finished that left procedure off 1061, and I came back to the right ear. We're probably at the stage now, what you're watching now is when I came back after I focused on the left ear. But actually I had to get this patient back, and I'll show you the moment. You'll see the end of visit 1 and the beginning of visit 2. I'll kind of, when that happens, I'll let you know. And we used the hook, we tried everything. You can't use forceps, there's something to grab onto, unfortunately. So even using a hook this deep, I was very apprehensive about doing it, but we did manage to get the hook in without touching the canal wall, but they did find it really uncomfortable. And this plug is directly on their eardrum. So any pressure that you're applying, even if it's just kissing the surface as we are at the moment, it was slightly uncomfortable for the patient. Unfortunately for audiologists in the UK, we can't use local anaesthetic. And I'll come back to that in a minute. You can just see the canal wall, probably about 10 o'clock. It's really spongy, that's inflamed. It's just, as I said, it's engulfed this plug of wax. It doesn't want to let go of it. Now, I used drops on several occasions during the procedure. I even let it soak for about, not 10 minutes, but between about 6-7 minutes. I let it soak in the ear to break it up. And I used both olive oil drops and also sodium bicarb drops, but to no avail. So, still continuing at this stage. So it's slightly blurry, that's because I just put, as I said, loads of drops, and as we're vacuuming, it's also suctioning the drops. And I was getting a bit hopeful here, because you can see it's starting to come away from the side. So I was optimistic at this stage that I might be able to get this out today on their first visit. And then I'm trying to go underneath and lift this out. Quite often wax can get trapped in a region called the inferior recess, so towards the eardrum, about 1/2 centimetre, where there's a little pit, a little trench, if you like. And quite often wax can get trapped in that trench and that dip, and then you have to pull it away. So by going to the base of the earwax plug and going up and away, you're lifting it, trying to lift it out. And you can see around the perimeter all that white keratin, and that keratin is acting like double-sided sticky tape. Not only is it adhered itself to the wax plug, but it's adhered itself to the canal wall, and it's, again, that doesn't want to let go. So we've used the hook on a couple of occasions. It was just too uncomfortable for the patient. I had to stop, and I had no choice really but to continue with the suction. Now, with this plug of wax, if there was something sticking out, something I can lever onto, I could use forceps. I could prise onto it, but it's just a flat surface. So when you use the forceps, the tip of the forceps, because there's something to latch onto, it's going to poke into the plug of wax, which is then pushing the wax further into the ear, up against the eardrum, which already is on against the eardrum, and it will just be more uncomfortable for the patient. You can just see how swollen it is on this side when I'm suctioning the ear canal itself, because of the edema. So when you've got swelling like this, you've got to build up a fluid within the cells. And when I'm next to the canal wall, especially to the left with the sucker, the fluid inside the cells is getting attracted by the suction, and it's almost trying to get sucked up, which then causes the canal to collapse. So again, I'll just put loads of drops in here. I let it soak for a while actually. So I'm just suctioning the excess there. The patient's got their head tilted across, so this is the writer, as I mentioned, it's facing towards the ceiling. So I thought we'll have one last go before getting the patient back in. So we'll just go to the front part of the ear canal and back to the roof. So it's a very strange consistency. It had elements of this chewing gum consistency that I've referred to in the past, and this is not keratosis obturans. It wasn't a dead skin plug. It was actually wax. But now this is the most. So this is 3 days later. So I told the patient, because it was in so much pain as well, that it's probably, and at that stage though, that although there were pain, it was a bit uncomfortable for the patient, and that was why they experienced the pain. Their symptoms were alleviated somewhat. So I decided to quit while we were ahead, and I asked the patient to use sodium bicarbonate drops 3 times a day for 3 to 4 days, and we got the patient back in. So the patient came back in today, and you can see the consistency has changed. It's softened a bit, but it's still quite impacted. You can see it's the canal slightly less swollen, I would say, than the last time, but it is still trapping this. And so I asked the patient to soak this at 10 minutes at a time, so it's really penetrating. So yeah, it's not keratosis obturans, it is a plug of wax, and the core of it was very, very hard, but around the edge it was very sticky, like chewing gum. So you can see I'm just going from the bottom, just trying to lift it up. Now the ear is very messy and gunky. You'll see that once I've removed this plug, you'll see how wet and mucky this ear is because of the drops that they've been using. So I'm just lifting it up and away. You can see all this dead skin. Now, this skin was what was preventing it from coming out on the first occasion. So, and this, you'll see once I remove the plug, the ear canal is extremely widened. So it has got elements of keratosis obturans, but I don't think this is keratosis obturans because this is most certainly a wax plug, but there was some skin enveloping it. I'm just trying to tease this out now. So, whilst this was initially on the eardrum, you can see it's come away. We're near the entrance now, you can see all the cilia, so that gives you a clue we're near the entrance. I'm just trying to tease this out. Now the plug was larger than the entrance of the ear, so it got trapped at this stage. So I think I'm going to have to use a Jobson horn in a minute to lever and manipulate this out. So you can see it's very sloppy there. A bit more difficult because of the hairs at the entrance. So it's just got trapped. I think when you use the Jobson horn now, it's going to get over, behind, and just roll this forwards. So you can see the skin surrounding the plug and the corner is the plug. So got that out, and you can just see how still how gunky and wet all this is. And part of that's to do with the drop. So they felt of immediate relief of any pressure. So that came out again, a nice chunk. Now I'm just going to mop up as much as we can, so we still can't see the eardrum. So it's possible this patient's got a bit of a fungal infection. You can see these little black spores, which wouldn't surprise me with the heat we've got here at the moment and the condition the ear was in. So although the pain was gone, they're still struggling to hear a bit. You can see there's another plug of wax there. That was quite a solid piece actually. And if you look at the ear canal, you can see it's widened in the mid portion of the ear canal. It's still got its shape near the eardrum, but just in front of the eardrum it has widened a lot. And that is a hallmark of keratosis obturans. So might have to contradict myself and say maybe it was a semi-keratosis obturans and semi-wax as a combination of the two. Keratosis obturans is typically when dead skin in the ear canal, it fails to migrate out of the ear, and this dead skin then forms into a plug, and so the skin starts to migrate off the eardrum and it makes its way out partly, then it gets trapped and then it expands within the ear. With keratosis obturans, it's not a case normally of patients using cotton buds and pushing it further in, which it can be, but typically it can happen on its own accord. But with this, the patient most definitely had impacted this using a cotton bud. So maybe it's element 50-50 of wax and keratosis obturans. Now, eardrum's clear that this is just dead skin that was attached to the eardrum, and I'm trying to peel this off the hammer bone. And it was a bit uncomfortable for the patient, so I kind of stopped at this stage, and the hearing was significantly better. This should now migrate off the ear, but you can see it's attached itself. It's not ready to be removed, really. Just trying to peel down, you can see it's still adhered to the eardrum, but again, it wasn't affecting the hearing. Now, this region, again, I'm not going to get every little spec out, guys, saying I'm extremely happy to the point we've got it at, so is the patient, but what I'm trying to do here is just mop up as much as I can. At addition, this is all a bonus now. So this skin, it's half dead, it's half greys, and it's half still attached, and it just wasn't ready. So we just remove as much as we can that's ready to come out. And this is the rim. So this is, as I said, where the ear canal widens. It widens. This is the point at which it starts to widen, and it's almost like exposed bone there. So we be really, really careful. Is underneath this dead skin, we don't know what there is, and you can see there's a bit of exposed bone there. That is bone, just below the sucker. So decided to leave that portion. We don't want to be touching bone, making it really uncomfortable, and hopefully now this will start to heal. But the eardrum is visible. It's very mucky in there still. I'm just going to mop up a bit near the entrance, but it's given the patient great relief, and the hearing was restored. Because of this widening now, you can see this widening is more in the mid-canal, whereas typically keratosis obturans is a bit more medial, deeper in the ear. It's quite a bumpy ear canal, goes up and down. But I'm really happy with that. And I hope you enjoyed that video, guys. And it was an interesting one. I hope you're all keeping well and safe. And remember, do stay tuned. We've got plenty more videos coming. And be nice and be kind to each other. Thank you. Bye.